We have Fahad Rahman, founder and CEO of Lumi Health, along with Asif Ali, who is the Chief Medical Officer at Lumi Health. Gentlemen, I'll pass it over to you.
Excellent. Thank you so much, Heather. And thanks for the earlier participants for some great presentations. We're going to change things up a little bit by having two co-presenters for this conversation. Our topic is AI-enabled medication optimization for heart failure patients. We thought this would be a totally relevant discussion based on the profile of not only the scientific sessions, but also the strong importance in heart failure care. I'll put this slide up. We'll be really short on backgrounds. As Heather mentioned, I'm Fahad Rahman, co-founder, CEO of Lumi Health. I've done a lot of work in healthcare innovation. Before launching Lumi Health, I was with Geisinger Health Systems Innovation Group. Geisinger is a health system based out of central Pennsylvania. Did a lot of work with them on care model redesign and implementation. And Dr. Asif Ali is a renowned cardiologist, a heart failure expert, works in the Houston area, both as a clinical instructor with Memorial Hermann, also as an independent practicing cardiologist that works across the spectrum with pharmaceutical companies and med device companies, and also published research as well. So at a high level, why are we on this mission to really optimize medication management for heart failure patients? Really, we want to save lives and reduce the excess spend in the system by improving how cardiologists manage medications for heart failure patients. We know that this is a really challenging problem, and we'll get into that problem statement shortly here, but it's also a very leveraged opportunity to not only improve the clinical progression of these patients, but also to move outcomes, clinical, financial, and experiential outcomes at scale. What we're going to be talking about is an AI-enabled but multidisciplinary holistic approach that we feel and has been validated in the market of demonstrating not only improved impact, but also a sustainability and a scalability. So I'll pass the mic over to Asif here to walk through some of the challenges around medication management.
Great, thank you so much for having me on today to present. And oops, getting some background issues here. Okay, within the heart failure management, and I think this picture really paints the right picture. There are many challenges that we face with their patient's journey, in particular to HFrEF, which as we know, is the #1 hospitalization in patients greater than 65 with a mortality rate of 50% in 5 years. So this challenge really looks like a tangled ball of rope to me. And each piece of this rope may be owned by different persons in regards to HFrEF patients. Quoting the CHAMPS heart failure study, guidelines strongly recommend patients with HFrEF be treated with multiple medications, proven to improve clinical outcomes as tolerated. The degree to which gaps in medication use and dosage persist in contemporary outpatient practice is now evident and clear. Hence the increase in hospitalizations for HFrEF and an increase in morbidity and mortality. Further untangling this rope of intertwined HFrEF challenges includes suboptimal implementation of guideline medical recommended therapy, changing of the patient population or getting older with increased comorbidities, multiple guideline changes as we go through seeing these patients, the changing of medications by various healthcare providers that they may see, the missing of biomarkers to be able to collect data from the patients between the office visits and hospital visits, the polypharmacy, as you know, the lack of education and awareness of lifestyle choices and adherence to medications, and no prioritization in regards to these step edits. And this high rate of rehospitalizations that we see, and as we know, every time the patients go to the hospital, we have a decrease in life expectancy. So the question is, can we do better on medical guideline directed therapy and the integration of the data and compliance within our healthcare system? How do we untangle this mess of ropes and address the barriers in a streamlined stack methodology?
So thanks, Asif. And you know, one of the things that we think deeply about is how can we further optimize and enhance a lot of the things that are being done today, but maybe done not as consistently, or maybe could be done in a different way to develop systemization. So one of the things that we're bringing to the market is an AI-driven medication platform. So think of this as the tech piece. And what this does is, we can identify and optimize medication selection and dosage per guideline directed medical therapy. We can also develop deep clinical profiles of the patient based on what we know about their EMR data, so a lot of their experiential data. But then more importantly, we can use artificial intelligence-based models to start predicting emerging and rising risk, because one of the things that we often find in working with physicians is that it's often very difficult to say which patients to focus on beyond the ones that are on the calendar or the ones that may be contacting you or you're contacting them. So who are the 10 or 15 patients I really need to worry about today? The second is taking device data, particularly peripheral biomarker data from blood pressure cuffs, from weight scales and pulse oxes, to develop our day-to-day understanding of the physiology of the patient. So this gives us, to use Asa's point, understanding what's happening between office and hospital visits, and how can we develop our understanding to then better inform the optimization of medication therapy. But then lastly, and the Lumi team has done a ton of work with physicians, and we rarely ever hear physicians asking for introduction of more technology into their workflow. So the way that we try to increase the surface area with which physicians can interact with their patient base is having a pharmacist-led and nurse-supported team. There's clear evidence-based knowledge and research about using multidisciplinary care teams in a top of licensed manner. And what we do is extend the cardiologist's reach between these hospital and office visits, but then more importantly, having a clinical and ambulatory pharmacist on the team allows us to not only validate, but then escalate the most opportune improvement opportunities to the cardiologist in a time-sensitive but highly efficient way. And we found that this full stack integrated model has worked really well to systematize the work in this highly challenging area. Some of the preliminary research that we have from one of the clients that we worked with across 600 heart failure patients, just to give you some sneak peek of some early data. One, we found that 86% of the patients were actually not at target dose. When we did an analysis of all of the patients and their medications, and then compared that against the guideline-directed medical therapy for those drugs, we found that almost all of them were not at the appropriate dosage level. So there was an improvement opportunity there. And then we ran the same analysis against unique prescriptions against those patients, and we found that about 80% of those prescriptions were actually not at target dose as well. So we found two really immediate improvement opportunities. But then more importantly, we were trying to look for deeper trends here. And what we found was that in line with Pareto's rule, the 80-20 rule, that 75% of the total improvement opportunity across this panel was actually co-located in 3 classes of medications and 3 providers. So what that helped us really understand is how can we further titrate our improvement to then move not only overall compliance across the panel, but then more importantly, ultimately overall clinical improvements across the panel. And what we found was that there is a highly leveraged and focused opportunity, which we've been pursuing to improve.
So I'm going to jump back in and, implementing such a system, what kind of benefits and outcomes should we expect? And I think, one of the biggest areas that we've just talked about is the enhanced compliance with GDMT, really reducing that clinical variation as these patients through their healthcare journey, in particularly the HFrEF. Also accelerating the time for medication optimization, and we really say from weeks to hours. So there are a typical patient who would go into the hospital. We would get informed of that hospitalization and try to get these patients within a short period of time. But the fact of the matter is, many of these patients are seeing multiple providers, family practitioners, internists, ERs, urgent cares, and that information may not be coming back in a systemized way. And so really the practice of heart failure is actually, between the office visit and between the hospital visits. And what Lumi is trying to do is make sure that that actually happens. And then to improve that patient clinical and experiential outcomes, I think that's evident by collecting the biomarkers and the data and acting upon them. And then lastly, engage more patients more consistently, reducing the time burden of the actual physician by engaging through AI and looking at the appropriate utilization criteria and the guidelines that we know all too well for the AHA, ACC, and Heart Failure Society of North America.
So I know we're bumping up against time here. Really thank the American Heart Association for allowing us to participate. We're a proud member of the Innovator Network, and thank you again for your time. And one last point: the way that we think about this is in a very holistic, integrated model to really optimize the medication improvement opportunity, which we believe and which the data shows is one of the biggest unmet challenges, but highly leveraged interventional opportunities within this population. And Heather, I'll pass the mic back to you.
Thank you so much, Fahad and Dr. Ali. Great conversation. I think medication adherence is something top of mind for all of us as we look at great cardiac care. One of the questions that came in, great solution. Which patients are eligible for this program?
No, that's excellent. So, we find, and I'll tackle this first, and then Asif, feel free to jump in. Clearly heart failure is an age progressive disease. So we often find that patients who are in the 65 plus age category is where the preponderance of heart failure patients are today. So there's numerous payers that have different programs. So in terms of eligibility, ideally we're focused right now on the Medicare population because this is where heart failure patients disproportionately tend to be in. And also because, so there are programs within Medicare that totally cover the costs of the entire tech-enabled service approach that we cover, and we're more than happy to chat with folks about how that looks like offline in terms of reimbursement and the methodology. The other thing that we also find is that there are other programs out there for folks that are in risk and capitated arrangements or going towards the value-based care route, which is deeply familiar to us coming from Geisinger. Is that ultimately reduction of total cost of care is one of the main things to do in terms of value-based care. Or in capitated arrangements like Medicare Advantage. So what we're also building is the infrastructure for cardiologists and for health systems to be able to be successful in those areas, because I think it's maybe worth repeating, but everybody on the call probably knows is that heart failure tends to be one of the biggest cost drivers within a broader panel of patients, especially with that at that age group, and often can be one of the biggest areas for improvement or success in those programs. So Asif, maybe if you want to chime in, if you had any other thoughts.
I think you hit it on the head. And as a participant with Lumi, I've onboarded a number of our patients. It's gone fairly seamless. You just have to pick out the patients with HFrEF that are covered by the insurance, which Fahad's team has done very well. So thank you.
Great. So what I'm hearing is there's options to cover the cost. And they might come from payers, but there might be other strategies. So attendees, if you have other questions for that, please do message Fahad with that. A couple more questions in our last minute here. Does Lumi provide monitoring for side effects that may occur with GDMT when initiated, allowing for self-adjustments, then notifications to the care team?
Yeah, that's a great question that actually aligns with the core value proposition that we're offering. Oftentimes, what ends up happening is that there's various medication interactions across the comorbidity profile and the entire medication panel. And sometimes that has to do with dosage, sequencing, time of day, other factors, other exogenous factors or patient factors. So one of the things that we really focus on is not only having a technology-focused approach to identifying those things, but also with the care team and the level of connectivity, actual patient engagement they have with the patient population, understanding, validating what's happening with the patient. Sometimes maybe patients may be having adverse events that they don't even know, but a trained clinician like a nurse or a pharmacist could surface those things out. We also have embedded workflows that actually systematically, in a protocolized way, surface those things. So it's top of mind for us, and we actually are doing a lot of that work to identify where those adverse potential interactions may be to then surface those up for the clinicians like Asif.
Great, thank you.